One of my messages is that all PARP inhibitors are not the same.
Right.
They have different doses, different frequency. Niraparib is once daily, the others are twice daily. Different lipophilicity, different tissue distribution, different metabolism. The idiosyncratic adrenergic sort of complication. So I want our audience over time, we're into this for 5 years.
Yeah.
The first PARP inhibitor approved in ovarian cancer was in December 2014. So we're way down this life cycle. But these are different agents. Probably the most important is the indication. Why do doctors do what they do? They do so based on an indication because that informs reimbursement, and an indication is related to a clinical trial. But Michael, my question for you, we've talked about veliparib and niraparib. Do you think there's just going to be an opportunity to say, well, I'm going to use rucaparib or olaparib, let's just say in HRD positive patients in frontline maintenance? Or do you think payers and providers and the NCCN are going to hold us to these clinical trials? I mean, you know that olaparib and rucaparib is going to work in an HRD patient in frontline maintenance. You know it. So, but does that really matter what you know?
Well, I mean, I would. Most of the time,
That's
not.
a personal question, I think.
But I mean, it's interesting because I would add that to what you said before, which they're different agents. But I think from the efficacy standpoint, particularly in the BRCA patients, they're very equivalent. But when I was in Massachusetts, it was different. Now I'm in Alabama. Third-party reimbursement is actually pretty specific. I don't think you're going to be able to substitute, for instance, rucaparib, which not have a trial that supports it, willy-nilly to use it. On the other hand, I'll flip it back to be controversial and flip it back to Rob, which is based upon those results in VALIA, do you actually think that AbbVie will go forward with the registration? The reason I ask that is because they're late to the party.
Yeah.
There are going to be lots of drugs in that space. Yeah. Probably niraparib will beat them, and olaparib's already there, and Palo will probably extend it. And you've got some increase in toxicity. Maybe the hazard ratios aren't quite as good, and we know the concurrent treatment isn't effective. It's really a maintenance strategy. And that's a lot of marketing for that. What do you think?
So I like. Thanks for the question. I think it's. I think that it really gets back to what you're going to do when you're in clinic next week, right? So you have a patient you just operated. Shannon brought this up. You have a patient you just operated on, and you have your options of nothing in addition to chemotherapy, Bev in addition to chemotherapy, or now if it's approved for us and we can use it, a PARP inhibitor in combination with chemotherapy. So you can make that touch point right then. And we have, we talked about how strong the effect can be in patients who have BRCA positive, either tumor or germline. And then, although we included the HRD, even if we didn't have that information, we still have evidence from the whole trial population that we can use a PARP inhibitor in there. So I think that your first decision is going to be how does it fit with that? So are you going to use something then or not? So that's going to be the first thing. So for me, I do think if I had it available and I had a BRCA positive patient or I had an HRD positive patient, which I knew the data for, I would be totally comfortable giving it then because I know I'm going to have that efficacy that's supported by the trial. Now I wouldn't prospectively withhold it to get to the maintenance space just so I could use one of these others if I already knew I was going to want to use a PARP inhibitor right for it. You see what I'm saying?